to this age group, having access to information and services critically aligned with our country demand and supply, and facilitate a multi-directional and dynamic learning, dialogue, and debate, and to continuously measure and be accountable. In these next 4 days, we hope to reflect on the theme and where are we as SDGs are, the global strategy to end preventable maternal, child, and adolescent mortality, the global action plans, and the AHA strategy. And how will we intend to do this? We will specifically focus on the epidemiological profile in our landscape. Undertake this consultative processes for setting priorities in national and county adolescent health programs with key research priorities. Offer adolescent and youth responsive leadership. Of importance is the return of investment in family planning and contraception in this age group. I know a lot of us still say they are not sexually active, but the data will speak volumes for us. Let's work together with them and not at them. And finally, we hope to foster and strengthen partnerships, both multidisciplinary, multi-sector, and the public-private partnership, so that we engage, accelerate, and align and be accountable into action. Again, I want to take this opportunity to welcome all of you and hope at the end of this symposium, you'll have a paradigm mindset that reviews evidence and innovates policies towards addressing only one question: where can I act now? Thank you very much.
Wow, thank you very much, Dr. Ankihara, for a wonderful opening speech, for your strong words, and for already starting with a call to action. And I think it's very great that we, all of us, we think about what is the call to action from this symposium. What is the message that we are... Hello? Can I please ask to mute mics, please? So I think, Anne, really congratulations for this call to action that is kind of guiding us on what should be the message of this 4 days working together and in a real SDG space, getting all of us, leave no one behind, but getting all of us, all these different constituencies working together around adolescents and youth sexual and reproductive health and health in general. So again, for those who joined late, I have the pleasure to welcome you. My name is Prof. Marleen Temmerman from Aga Khan University, and I'm chairing this session together with my co-chair, Prof. Malwa, who will take over and lead the second part of this session. Without further ado, it is my pleasure now to call upon Dr. Bashir. I hope he is, I don't see the list, but Dr. Bashir is on the program to give us an overview, and he is really in an ideal situation with the Ministry of Health to talk about the status of sexual and reproductive health amongst adolescent and youth in Kenya. Dr. Bashir, the floor is yours.
Dr. Bashir is just logging in now, so okay. Maybe we can go to the next speaker, then he'll speak immediately after.
Thank you. Thank you. So the next speaker is somebody that I can introduce with a lot of confidence and pleasure. He is Dr. Ferdinand Okwaru, working as one of my colleagues in the Center of Excellence for Women, Adolescent and Child Health, which is a research center here at Aga Khan University. And Dr. Ferdinand Okwaru is leading a study taking place in 3 counties in Kenya, but looking at the impact of COVID and the mitigation measures on adolescent health. Ferdinand, the floor is yours.
Thank you very much, Prof. Marleen, for the good introduction. I hope everyone can hear me well. I already shared my presentation, so I probably need to share my screen then, because I'm not so sure that there has been enough time to upload them in the central place.
We can see your presentation, Ferdinand, and I forgot to say that Dr. Okwaro is a social scientist, anthropologist. Floor is yours again. Thank you.
Okay, you can see my screen? Okay, thank you. And thank you to the organizers and for everybody who tuned in to listen to my presentation. It's a pleasure. Could we go to the next screen? Yeah, I'll just go quickly through this because Prof. Malin already said that this presentation is based on an ongoing project on the impact of COVID-19 mitigation measures in Kenya on sexual and reproductive health. And it's a program it's a research project for 9 months running between July 2020 to March 2021. And we are funded by the UNFPA. Shall we go to the next one? That's just the research team, just to emphasize that this is not just my work alone. I don't want to take all the credit for this. So we're working in a team with Professor Malin as a PI and me and my colleagues as co-Is, but we also have support from residents, other team members, consultants, and also getting technical support from the UNFPA. Next slide, please. So what's the rationale for this project? To say the COVID-19 mitigation responses are necessary. And we all do appreciate that with a pandemic of this nature, we cannot just sit back and watch. However, learning already from this pandemic, but also from other pandemics like Ebola that ravaged West and Central Africa, we realize that such mitigation measures might have other adverse effects, other unintended consequences. That's why I say with respect to our topic today of sexual and reproductive health and for the adolescents and the youth, we say these measures could affect the health of populations and especially the SRH of resource poor populations. And here we're talking about women of reproductive age. So the focus here would be resource poor populations as well as women 15 to 49 years for the entire project. But in this discussion, I'll be looking at adolescent sexual and reproductive health. And we're talking about people between 10 to 19 years of age. I realize the focus of the symposium is adolescents and youth. But just to clarify, I will be talking mainly about the adolescents, 10 to 19 years of age. Why? Because these measures, again, will lead to disruptions in the demand and access to essential sexual and reproductive health services. And we'll see this from the experiences of the adolescents that we encountered in the project. Next, please. What is at risk? What happens with these disruptions is that this will risk the commitments made by governments at the International Conference for Population and Development that was held here in Nairobi. This is where a group of countries came together and made a number of commitments, and the governments committed themselves that by year 2030, which also, as Dr. Kihara already alluded to, the SDGs that we'll be looking at in this conference, that countries committed to end all preventable maternal deaths, to ensure that zero unmet need for family planning, and also to end all forms of gender-based violence and harmful practices against women and girls. This is to be achieved incrementally to the year 2030. And our argument here is that the disruption brought about by the pandemic or the mitigation measures adopted during this pandemic will risk achievement of this. Let's go to the next slide. So what are the broad objectives? Before I even just go to the topics, what are the broad objectives of our broad objectives for the study? Is that we are examining the ways that Kenyan COVID-19 mitigation responses could affect sexual and reproductive health of poor populations with focus on women 15 to 49 years of age. And also we are studying the sexual and reproductive behavioral changes and psychosocial constraints on individuals, families, and communities with respect to SRH demand and access. We have a couple of assumptions or what people could call hypotheses. In this project, we think population growth could be affected in terms of having a baby boom soon after the pandemic is done, or more than about 9 months after the pandemic. We also assume or hypothesize that maternal and newborn health might be affected. Adolescent pregnancies, which now touches the core of this symposium, could be affected or they could rise, but also sexual and gender-based violence, domestic violence, or harmful practices such as female genital mutilation or early marriages would increase. Next slide, please. A bit brief on the methodologies that we are using, a mixed methodology. We're looking at the literature review. I already alluded to the case of Ebola. We're using qualitative methods, using having key informant interviews and focus group discussions. The key informant interviews are with community leaders, healthcare providers, community health volunteers, members of the judiciary, members of the police force, teachers, etc. For the focus group discussions are mainly with the community, and this is where our adolescents came in a lot because we organized several focus group discussions with them in Kilifi, Nairobi, and Mombasa. We also have the quantitative methods, of which I will not present a lot. Other presenters in this symposium will talk about that. But for our project, we look at both the quant and the qual. Next one, please. So just from we did focus group discussions in Kilifi, Nairobi, and Mombasa with adolescents 15 to 19 years old. We did a total of 9 focus group discussions, 3 in each location. In this presentation, although the title talks about Kilifi, I'll be discussing findings from the 3 counties, mainly because, first of all, Kilifi did not generate specific findings that are different from the rest of the 2 counties, but also the number of focus group discussions with this focus group, are not as many as to generate a comprehensive picture. The focus group discussions were both for males and females, and majority of them were school going, either in boarding schools or in day schools. For this presentation, I'll concentrate more on the views of the adolescents, but with corroborations here and there from the key informant interviews with other respondents who are non-adolescents, but the bulk is the views of the adolescents. Next, please. So with respect to the mitigation measures, which I believe we are all familiar with because they've been stated many times, it was written, head of state, ministers, etc., heads of facilities have repeated these mitigation measures all over. But for this, I would like to distribute them into 2. We have the general mitigation measures. By this, I mean mitigation measures that cut across the entire population, including the adolescents. So we have the information, education, communication, we have respiratory etiquette, coughing on the arm and, sneezing away, hand hygiene, washing of hands, we have masks, etc. So we are familiar with all these mitigation measures. But when we go to adolescent-specific mitigation measures, for most of the people we spoke to, it was about school closures, but also closure of social activities or social centers within the community. Also suspension of youth outreaches or inreaches and sports activities. These are some that directly affected the adolescents, but also, as we shall see, some of the measures affecting the adolescents had traction or affected the adults. I mean, some of the measures targeting the entire community, like parents, also in a way affected the youths or the adolescents that we are talking about. So they're both direct and indirect impacts of the measures. Let's go to the next. So what are some, that was just by way of background, I'll go to some of the experiences or what we realized or what was reported to us by the youth is that Majority of the youths we engage in FGDs, as I said, were in secondary schools, a few in primary schools. So the biggest disruptions was on their schooling. And when speaking with them, what we realized is that there was a mixture of both anger, despair, and boredom. Because by the time we were conducting these FGDs around October, November, there was still no indication of when schools would reopen. And as you can see from one of the comments there, one of the kids in Kilifi, one of the adolescents, said, we have been at home all this time. We don't know when the schools will be reopened. Nobody is speaking to us about alternatives. How can we spend our time? We are told online learning is continuing in some schools, but for us, that is a dream. We don't have laptops, no internet and electricity, etc. So the adolescents were asking, we hear in the press or in the TV that we can do online learning. How do we do that here? So according to them, there was an exacerbation of the gap between the rich and the poor. Kids, adolescents from rich families who could afford internet and laptops were obviously in good schools that could organize Zoom, etc. Are the ones who are able to benefit from this mode of learning. The rest were left to fend for themselves or their parents. And so there was anger, despair, and boredom. Next, please. So one of the hypotheses for this project was that adolescent pregnancies could increase as a result of the COVID-19 mitigation measures. Like I said, we have a quantitative component that looks at the figures, and they will definitely give us a clear figure or a clear magnitude of what the problem is, of course, compared to the other years, not just necessarily to COVID. So that we can see if the actual change is due to COVID or due to other reasons. The media have also reported variously on this topic, and as usual, the media will sensationalize everything. So there is always need to skim through to get the real situation. However, from our participants, many of them observed that they knew at least one colleague or one person in their neighborhood or in their school who may not resume schooling due to pregnancies. As a quote there, one of them in Nairobi actually said, we are worried that many of our classmates will not resume schooling when schools open because they're pregnant. In our neighborhood, for example, I know 2 already who have been impregnated. So when talking to them, we'd ask them, is this a problem? And do you know actually somebody who may have become pregnant during this time? And in all the focus group discussions, the young people said, yes, they know someone like that. Let's go to the next one. So generally, I will start to find out how is it that many of them became pregnant and who were the responsible. So we have the usual suspects, the older man with surplus cash and the free and bored girl connection. So it's a repeat, it's just an exacerbation of a problem that we already know. And for places like Kilifi or the poor neighborhoods, it's not the big man with the big car, it's the man next door with 100 shillings or 200 shillings who is able to buy some lunch or buy a pad or buy something. We also have the conniving motorbike operators who are notorious for having sex with young girls. But also what was surprising to us, and it probably has been reported, is that they said it's also their classmates. They are having sexual interactions with their classmates, some of who come from rich parents, and some of the parents may have bought them motorbikes. So there's that connection. Let's go to the next one. Next slide, please. So parental care, poverty, and pregnancy, this is an indirect effect. There's a connection also between the lockdown, which generated loss of income, household resource scarcity, and therefore increase in adolescent pregnancies. We also have cases of parents enlisting their teenage daughters to support in business. Again, not very new, but exacerbated by COVID. As the quote there says, is one of a girl whose parent asked her to join in the business, and they selling fruits, and therefore she became easy prey to the people, to some of her customers. Let's go to the next one in the interest of time. So also the youth centers, recreation and access to SR information and products, there's also a connection here. Social distancing rules led to the closure of recreation and youth centers, from where the adolescents obtained information and products on ASRH as well as sometimes donations of essentials. For instance, in Nairobi, we had a case of they mentioned the program called Binti Shujaa that gives information and product and support to, especially to adolescents who become pregnant, through the channel of youth halls. And therefore, when social distancing and social halls were closed, such a program became difficult to progress with. Next, please. Again, lack of sports, boredom and drug abuse. There's a connection between sports prescribing, boredom and drug abuse, and the emergence of criminal gangs, especially for boys. This was mentioned mainly both in Nairobi and in Mombasa, where the adolescents observed that most of their colleagues had become drug addicts, but also some had joined criminal gangs that were robbing the areas. Next, please. For sexual and gender-based violence, many of the adolescents stated they were not really involved, or they don't notice most of that. But in a few FGD, one or two FGDs, they mentioned the fact that in some cases, parents were pushing their daughters into sex work to obtain money and support their households. So the quote there says, some parents are indirectly asking their daughters to engage in sex work. Your parent tells you, we cannot be two women in the house yet go hungry. Go out there and get us something to eat. Where else can one get money to buy food? From a man. So this was a bit shocking or surprising for us, because we had sort of hypothesized in this project that maybe parental guidance, or when the adolescents are at home with their parents, but their parents will guide them or have close contact and watch them morally. But this is the opposite. Next, please. So finally, just to conclude, is that although when we talk about lockdown measures, the first thing that comes into people's minds is the schools are closed down. But school is not just a learning institution, but it's a hub against which many innovative adolescent sexual and reproductive health programs are hinged. They do learning in schools, but also other projects such as school feeding, sometimes provision of essential supplies, identification of needy adolescents and linking them to counseling services happens in schools. So it's not just the absence of learning, but it's also the absence of services that are usually that piggyback on the school system. So their closure led to the collapse of many programs, leaving the adolescents vulnerable. And this was an interesting quote, even from the community leaders say, these kids belong to the teachers. We as parents, we cannot manage them. Last one, please. Next, please. So what do adolescents wish for? What do they recommend? First of all, as I say, they need consultations with them on best ways to effect mitigation measures. Many of them said, we don't know where those measures came from. None of us were involved in the discussions. They also beg that all formal and informal institutions should remain open during pandemics. They call for standardization of schooling facilities to enable both in-school and virtual learning for all schools. They also called for parental discipline. It was not lost on them the cases that were reported in the press of parents who are organizing in their homes, young girls and boys engaging in drink and smoking and sexual orgies. So they said some of our parents are not disciplined, so they called for that. And also they called for that do not outlaw youth activities without finding an alternative for them. I was a bit surprised that in Kilifi they mentioned specifically that they want disco matangas to be allowed. But the disco matangas were, I think, outlawed even before COVID-19. So in a nutshell, these are some of the experiences that are mentioned by the youth with regard to the pandemic. And so I would like to stop there and acknowledge my colleagues. Just the last slide. That's my team members, the AKU, the IRC, NACOSTI for allowing the project, the UNFPA team for both funding and also for technical support. I would like to stop there.
Thank you very much, Dr. Okwaro, for a really wonderful, very interesting presentation. I think you will all agree with me, and there are a few questions in the Q&A, but mainly, first question is, can you please share your PowerPoint, because there are other people attending this symposium who are interested or doing similar work, but I think that there is a policy on sharing the presentation. So Dr. Kihara will inform us on this. And I'm sorry to say, but because the time has been used, time is up. I would refer or defer questions and comments to the last part of our session this afternoon, when we have a discussion. So then you still have an opportunity to ask questions to Dr. Okwaro, and of course you can put them in the chat box. Having said that, it's now my pleasure to welcome my good friend, Dr. Bashir, who will, and we are very happy, Dr. Bashir, that you found time to join us this afternoon to talk to us, to this large group of 322 participants on the status of SRH amongst adolescents and youth in Kenya. Dr. Bashir, the floor is yours. Karibu.
Thank you very much, Professor Marlin Timmerman. It's my pleasure to be here today. Apologies, I was traveling and I had to find a space to do this presentation. Can I share my screen? And I cannot see how to do that from here. Yes. Thank you. Allow me to share my screen. Where is my presentation? Okay. Mine is to give you an overview of the status of adolescent sexual reproductive health in Kenya and what as a department or as a division we are doing. Are you able to see my screen? Can you allow me to share? Looks like. Can you hear me, Professor?
We can hear you very well. I hear your question. I don't know who.
I'm trying to share my screen, but
yeah.
Yes, we have allowed you to share. We have allowed you to share.
Okay,
yes.
good. Now it's there.
Yes, now we are there. Thank you.
Good. Having already spent time, my apologies again for coming in late, but it was challenges of the road. I will talk briefly about the issues of adolescent youth sexual reproductive health in the country. And that's the outline, who are adolescents and youths, definitions, adolescent and youth sexual reproductive health issues, and response to the same issues. What is it all about, adolescents? Why are they a peculiar and important group? First of all, an adolescent is a person between the age of 10 to 19 years of age. This is the WHO definition. And we have about 11 million according to our last census. What are the issues about it? They have relationships with parents, with self-finding myself, defining who I am, exams, school, career choice. There are many things that are going in their head. Physical growth, emotional development, sexual masturbation, or sexual urges for that matter, cognitive development. All this is an overwhelming array of events happening in their head. So you see physical beings walking, and sometimes you judge them as adults, and they may be going through a lot. So that's a definition of what adolescent is. What about them? In Kenya, the Constitution of 2010 defines youth as those who are aged between 18 to 34 years, youth. The conventional population of youth aged 18 to 34 in Kenya is about 13.7 million, which is about 29% of our population. Are they important or not as a category of people to be given focus and are targeted for their needs? Yes, they are. The United States, the nations defines youth as those persons between the ages of 15 and 24 years. For this presentation, we will limit the conversation to up to 24 years. And what are the issues? It's the way this emoji is holding its head. That's what exactly is happening to the youth, to the adolescents in their head. The scope of SRH is sexual debut, which is both physiological and social, sexual gender-based violence, which is a major issue that has come to the fore also after COVID lockdown, child marriages and harmful practices like FGM, childhood pregnancies and motherhood, HIV and AIDS and STIs, marginalized and vulnerable adolescents, those who are left on their own without parenting or with HIV, AIDS, and this. These are reflected among young people in varied degrees. And sexual reproductive health pertains to the state of physical, mental, and social well-being in all matters related to the reproductive health system. Sexual debut. We usually refer to a lot of statistics, but this gives us an inside view, an internal, or rather, an disaggregated statistics on different age groups and ages. Between 15 to 19 years of age at first intercourse of 15 years is about 10.7. This is for female. For male, it is 19.6. So it's almost double. First sexual debut for 20 to 24 years of age. Those who started their debut at 15 years of age were 13.6 for female and 22.6 for male. So you see the female are starting later, the male are at higher at the first sexual debut. So when they're 18, it goes to 42.3, and for female, and for male, it is 51.2. Therefore, from this slide, what we are seeing, the take-home message is that sexual debut is lower with the younger generations of today than the previous people. And secondly, the sexual debut statistics is higher with the male adolescent more than the female. If you look at 15, it's 10.7 for female and 19.6 for male. And the same for 20 to 24, both male and female. The male start earlier. And therefore, by age of 18, 42% have had their sexual debut, 18. Therefore, where do we need to focus on? Already, 90% are not sexually active by 15 years of age, or 91% or 89%. Therefore, what should be our focus? To strengthen this abstinence or actually to dangle contraceptives for them? It's a question for the forum, and we will also share what as a government we are thinking.
Dr. Bashir,
Yes.
Bashir, sorry for interrupting you, but a lot of people are asking, could you make a slide presentation, a full screen?
Yes, definitely. Sorry. Apologies.
It's okay. Sorry for interrupting.
Over to you. Yes, is that okay? Sorry.
Yes. Thank you.
1 in 5 females experienced sexual gender violence before the age of 13. This is what you call violence against children, report of 2019. So, and if you look at these stats, the largest majority of people who experience this sexual gender-based violence are the cohort between 12 to 17 years of age, and mostly female. You can see 12 to 17 years of age. In 2020, we had 10,650 reported cases for female, and male is 309. You can see the statistics are not rhyming. If you compare that cohort with 18 to 49, although the age interval between 18 to 49 is larger than 12 to 17, the number of 12 to 17 suffering gender-based violence are almost 2.5 times. and therefore they are an easy prey to be to suffer, to become a victim of gender-based violence. And that's why it's important that we need to really move them out and look at them with a different lens in terms of SGBV. Access to maternal health and skill delivery and maternal deaths. In 2018, our percentage of SBA was 65, 2019 was 67, 2020 is 77.8. Out of this, 10 to 19 years of age were about 29 to 30%, 28 to 30%. So is this important? Are they contributing to more of our maternal mortalities or not? They could be. Total maternal deaths are that 1,000 as reported or as audited. And then out of that, we have, in 2019, we had the highest, 279 adolescents who died while giving birth. The deaths audited are almost within the 900 out of the 1,000 that was reported. So we are not almost, we are not 100%, but we are doing some progress. Therefore, what it shows you that they are becoming pregnant, they are becoming mothers, and they are not being given the care that they require at this age. So coming to the issues that are affecting the adolescent sexual reproductive health or adolescent at this age, child marriages and FGM, which was alluded to by the previous speaker who did the research in Kilifi. And by the way, we visited as a national task force, adolescents in Kilifi, and those FGD responses as it is, and things could even be worse than as reported. So 21% of girls between 15 to 24 years of age have experienced some form of FGM, and 6% were married by the age of 15, while 26% at the age of 18. This is KNH 2014 and 2009. Childhood pregnancies are a reality. 18% of pregnancies occur among girls of below 18 years. HIV and AIDS and STI, it's estimated that there are about 105,200 adolescents aged between 10 to 19 years living with HIV AIDS, and 2,100 adolescents die each year due to AIDS-related conditions. 8,200 new infections occur annually in this population. These are estimates from 2018. Other issues like RT cancers because of the HIV AIDS and the rest, menstrual health and hygiene are also things that can really have them drop out of school or put them into early sexual affairs for favors that can help them buy maybe the parts. That's what we recognized, discovered in Kilifi. Most of the girls were giving sexual favors just to get the parts. The top 5 drivers of poverty in SRH outcomes are, poor SRH outcomes are poverty. And this is the major thing that we have discovered in our interaction with the adolescents and with the communities in Kilifi, for that matter. I'm not sure whether there's any other county that is actually stands worse than Kilifi. We're yet to, and hopefully this study will shed some light. Sexual violence and retrogressive cultural practices, the child marriages, and the violence which I've just given the statistics. FGM, the toxic triangle, where influence of peer pressure and new media against adolescent and youth, people's lack of requisite knowledge, skills, values, and attitudes to make concrete decisions, and suboptimal parental support. The girl is just left to be on her own. The parent is happy enough that once she starts sexual activity and she has a baby, she's out of the bomber, so that he doesn't assume responsibility for her schooling or even for taking care of herself and her baby. So they are happy to get rid of them. So that's what you call suboptimal parenting. In the first place, if there is proper parenting, it will have been very difficult for this child to fall into that network of early pregnancy. Drug and substance abuse is an issue, and this also pushes them into early sexual debut and maybe drop out of school. Suboptimal segmentation and responsiveness in health service package, for a highly heterogeneous population. 10 to 17 are different from 18 to 24. Their needs, their mindsets, their requirements are all different. Rural versus urban, sexually active versus non-sexually active, adolescents with children or those without children, adolescents, people living with HIV/AIDS, adolescents in school and out of school, minors versus legal adults, which are 18, 19, 20, or maybe require segmentation to respond to their needs, but we are putting them in a block and trying to serve them from one point of entry. The scope of MOH response to SRH, we as a government are trying to ensure that we have an enabling environment by ensuring leadership, policy, governance, accountability, and financing for adolescent health. We are advocating for that. Empowering adolescents and young people as critical partners in their own health, which is involving them, the consultation which Dr. Aquaro was talking about a few minutes ago. Strengthening the capacity of parents, teachers, and other duty bearers in their shared responsibility for adolescent health. We actually feel it is a failed parenting and a failed system, a social system, than actually just looking at the government. Ensuring access to equitable, quality, and adolescent responsive health services at school, community, and health facility, because there are a lot of youth and adolescents who are out of school. Where will they get their services? Sustaining community advocacy and engagement for collective support and protection of adolescents until they are able to make their decisions on judgments. Strengthening data, monitoring, evaluation, research, and surveillance on adolescent health is lacking. It's just piecemeal, small things that are happening, but we don't have a proper survey that can really give us an in-depth analysis of what their needs are and what statistics are. Strengthening partnerships and coordination for this matter, so that we are all in sync, the NGOs, the civil society, the government, the parents, the schools, the different departments and ministries of government are really make it an agenda for funding and for government accountability. So what? Organizations' ability to learn, translate that learning into action rapidly is the ultimate competitive advantage. That's what we say. So if we come together as a team now, I think there are about 300 professionals here from different angles. We need to learn from what we need to, the lives and the future for this adolescent in Kenya. Reflecting on the responses, we have persisting poor ASRH outcomes in a highly dynamic and heterogeneous population. We have significant work is being done to respond to issues, albeit mostly one size fits all, not entirely responsive, nor comprehensive, and not accountable. The laws provide a conducive environment for responding to general SRH needs, but not optimally implemented. There are also subgroups not articulated within the existing laws. The available policies and guidelines are not harmonized. There are gaps in articulation of certain subgroups of vulnerable adolescents, and multi-sectoral approach is critical, but not entirely optimized. The key action points here: an in-depth situational analysis on AYSRH program that includes a comprehensive assessment of policies, guidelines, and interventions and best practices for Kenya. To develop a key ASRH revolution roadmap, which includes a responsive, comprehensive package with a deliberate implementation framework, which is fully funded. Review and participate or advocate for review of the existing laws, policies, and guidelines on SRH and harmonization of the same. What does it take to get there? The will to change one size fits all, the methods that are alive to our cultures and our values and context, manpower and money, the skills and our brains, our time and efforts, and the funding to implement those and to ensure that those girls or boys don't fall off the cliff, and the tools that are responsive, which are the guidelines and the data collection tools for that matter. So it's true, they say there are many ways to skin a cat or to make a good move from one point to another. But it's apparent from these photos, some ways are harder than others. In North Korea, a soldier had difficulty getting goats to obey his orders. But somewhere in Kenya, a cyclist found an easy way to get the same breed of animal to cooperate. One only hopes that the goat on the left did not feel the need to answer a call of nature. But there are many ways that we can deal with, and it is all about coming together, putting our heads together, and charting the way forward. Thank you, and over to you. I hope I have not taken longer time than expected.
Thank you so much, Dr. Bashir. You have really respected time. Just 1 minute left, so that is good. Thanks for your very interesting, informative presentation, and also kind of the way forward. We don't have much time for action, for questions now. And looking at your last but one slide, I think what we also need actually is a partnership and leadership and a good call to action. And maybe at the end of this symposium, we can come like, is there an intention from the Ministry of Health to work together with Ministry of Education and to really form a strong task force to move this agenda forward? I'm not expecting an answer now, but just before I hand over to my co-chair, Prof. Alma, I just wanted to throw that in the group and hoping that because we need to come with this from this symposium with a call to action. So again, thank you very much. And now it's 3 o'clock and I have the pleasure to Prof. Alma doesn't need any introduction here in this group, but to hand over to him for to share the second part of this session. Thank you very much.
Thank you very much, Professor Temmerman. Colleagues, we're actually having a very good symposium and we'll proceed. Our next speaker is Dr. Manguro Griffin, who will talk to us about the SRH during COVID-19, the lessons that have been learned. Remember, continue putting your questions on the Q&A. We are going to have time at the end to address those questions. So I'll welcome Dr. Manguro to take the floor. Please welcome.
Thank you very much, Professor Mamanwa. Thank you very much, Professor Marlene Temmerman. Indeed, it's a great pleasure to present to you this afternoon. Let me just share my screen in a moment. Yes, so we are here. Can all of you see my screen?
Yes.
Could you confirm if you can see my screen?
We can see it.
Yes, we can see a screen.
Yes, Dr. Manguro, it's very clear.
Okay, perfect. So thank you very much. So I'll probably, the best way to say this is I'll complement what the other two presenters have spoken about. But before I go ahead and do that, I'll be discussing on adolescent and young people's sexual and reproductive health during COVID-19. As Professor Amalwa said, my name is Dr. Griffins Manguro, and I work for the International Center for Reproductive Health Kenya as the director of ICRH Kenya. It gives me a very, very great pleasure to make this presentation in front of you. And I hope, just very briefly, so for us at ICRH, we are a research and intervention program organization, and the vision is to be a center of excellence in sexual and reproductive health research and interventions. And the ICRH mission is to contribute to the improved health status of Kenyans by designing and implementing really innovative and evidence-based and cost-effective approaches, and carry out research that is capable of influencing public policy in the field of sexual and reproductive health. Specifically, we are looking at 4 main areas of sexual and reproductive health, and that is 1, adolescent and youth SRH, 2 is HIV and STI, 3 is family planning and maternal child health, and 4 is sexual and gender-based violence for all populations. And the work that I'm presenting to you this afternoon derives from two main projects from ICRH. The first one is the Performance Monitoring for Action, or PMA for Action, program carried out in Kilifi County. And now the Performance Monitoring for Action is actually a national, we actually carried out two parts of the PMA for Action survey. So the first one was the PMA for Action General annually. Maybe this is the 7th year now, and we collect data on several indicators related to gender, health, and socio-economic activities. And basically, we look at changes in these indicators over time and provide counties and the national government with the relevant data on changes and progress of SRH indicators, with the aim of sort of using this data to make decisions. Second one was a smaller survey that was done specifically on adolescents and young people aged 15 to 24 years. And this was carried out in Nairobi County specifically. Both PMA programs are funded by the Bill and Melinda Gates Foundation. And basically they were started as a way of monitoring progress towards the AFP 2020. Of course, it has morphed to be more or less data collection at both national and at county level, and to integrate the use of this data into interventions at both levels. And the third program is for the first time by UNFPA. So I'm making this presentation on behalf of many people, including the PMA team led by Professor Gishangi, who's also one of the presenters. I think he's, of course, Professor Malin Temerman, who has worked a lot with ICRH in the past. So moving forward, the next thing is just looking at what's the current status of adolescent sexual and reproductive health in Kenya. And a number of interesting things regarding ASRH. And one of them is that we have actually improved compared to 1994, when we first had the conference, the ICPD. On quite a number of these SRH indicators as a country, we've improved, which is a good thing. But unfortunately, we haven't improved to the extent that we thought we would. And at the same time, we have variations within various parts of the country. So like, for example, we now have adolescents and young people are likely to marry a bit later than before. They're also likely to have a later age at sexual debut. I think in 1990, in the 2009 KDHS survey, we found that the median age at first sexual intercourse was around 18.2 years for girls. Now, if you look at the graphics here, it's more or less the same thing, although for rural women, it's actually gone down. This is data from 2020 December, PMA 2020 December data, and this is data that we just disseminated in March this year. So if you look at the median age at first sex for urban girls is around 18.2 years, for rural girls is about 17.1. If you look at the age at first contraceptive use for urban girls is about 21 years. Rural girls or girls living in rural areas start using family planning at a much later age. If you look at the age at first birth, it's around 21 years for girls living in urban areas, while for girls living in rural areas, it's about 20 years. And if you look at the first marriage, again, 22 years for girls living in urban areas, 20.5 years, sorry, for girls living in rural areas. If you compare that to 2009, it was about 19 years. So we've had some slight improvement in terms of some of these social and demographic indicators. Unfortunately, between girls living in rural counties and those living in in urban counties, which is something that I think as people who are keen on intervening, probably quite important to note given where to focus our energies now. Now, if you look at the general effect of COVID-19 on health and on the socioeconomic status of young people, one of them is that COVID-19 disrupted the economic status of most young people. And young women, unfortunately, were more affected than young men in terms of their earning and the ability to be self-sufficient. So, for example, about 54% of young females reported an increase in financial reliance, either on their partners, on their parents, on their peers, compared to about 36% of young males. And this again just tells you about the distribution of vulnerabilities between the various genders in the country. So basically what COVID did was just exacerbate something that was existent there before. So of course we did both quantitative and qualitative interviews, and one of the things we found from the qualitative interviews, just to corroborate what was reported in the quantitative survey, was that quite a number of these young people either lost jobs themselves or had members of their households who lost their jobs. And as a result of that, there was a lot of things changing in terms of social and economic status. This presentation, I'm making the presentation, I refer to young people from 15 to 24 years. Now, in terms of access to services, again, we noted that there was a lot of disruption to access. The two main factors that hampered young people's access to healthcare during COVID-19 period. The two most common causes were fear of visiting health facilities and fear of contracting the disease, and secondly, the government restrictions to movement. So if you look on the right, we have about 51% of young women and 32% of young men at some point attempted to seek services during the COVID restrictions and couldn't. If you look at the two, young men reported more difficulty to get services due to government restriction compared to young women. And specifically to young women, again, over half of them experienced disruptions in accessing menstrual health products. And one of the things they reported was most of these menstrual health products are provided through non-profit organizations, and many of these non-profit organizations closed down during the COVID-19 period. And this just shows you the importance of having some of these considerations before we put down measures like lockdown measures or restrictions to movement. If you look at access to contraceptive services for young people, again, about 53%, and looking at PMA data for 2020, about 37% of young girls between 15 to 24 years who are sexually active are currently using a form of modern family planning method. At the beginning of the pandemic, we estimated that about 10 million unintended pregnancies will occur over the next 1 year. If at least 10% of women experienced disruptions in contraceptive services. Of course, we haven't gone back to see how many unintended pregnancies have been caused or have happened over the last 1 year. But I'm sure the scenario isn't quite far from this. One of the things we noted was that about 35% of young women and 40% of young men report difficulty in obtaining contraceptives. The more important point here is actually that many of the people who had difficulties in accessing family planning were people who used coital-dependent contraceptives, so specifically condoms and morning after. So of course, with this, the chances of the likelihood of unintended pregnancies among young people is likely to be quite high. There are several reasons why young people had restrictions in access to contraceptive services. The most common of them was that they were afraid of going to the health facilities and fear of being infected with COVID-19. But equally important were the government restrictions to movement, and also the fact that many of the service points, especially individual and private doctor clinics, were closed during this period. We found from focus group discussions, some of the things is that people were afraid of going to the hospital because they didn't want to be tested for corona and found positive, because they're afraid of getting quarantined if they were found positive. And similarly, from a healthcare provider, one of the things that she feared was that because of the disruption to movement and travel, then quite a number of the would be unable to come, which would, of course, result in gaps in FPUs. Now, the second thing, which was equally interesting, was the effect of COVID-19 on young people's sexual autonomy and privacy. And this is as a result of restricted mobility for their parents and for the other members of their households. And so basically it meant that either there would be quite a number of people at home who are not going to work, or there would be other members of other relatives who lost jobs, and as a result who are unable to pay rent, and as a result moved in with other family members. Now, interestingly, about 76% of young girls and about 50% of young men experienced less privacy at home during COVID-19. And of course, this also had its effects on some of the sexual reproductive health services. So during one of the focus group discussions, one of the young girls said that, someone like your sister and your mother, because they're at home, they're not going to work. You find one day she goes into your room and she finds things like contraceptives. And as a result, you end up getting stressed. So quite a number of the young people either could not take up family planning use, could not take up health services, could not use some of these services that they would otherwise use because of that lack of privacy. The third thing, or the third effect on COVID-19 on SRH for young people was sexual and gender-based violence. So I think, as we've said this in the previous presentation, SGBV is quite common among young people, especially in Kenya. And during COVID-19 period, we had an increase in both intimate partner violence and sexual harassment. Now, what's interesting is that there was actually a greater increase in intimate partner violence compared to non-intimate partner violence. So if you look at IPV, we had an increase of about 50%. If you look at non-IPV, we had an increase of about 35%. Now, both of them are significant, but what's worth noting is actually, it's likely that we had the increase in IPV as a result of several reasons. But it was more common among younger girls, girls who had a less of a secondary level of education, living in a house made of iron sheets, and who had a living partner. Again, a lot of this is probably related to the social and economic status of these relationships. And so it's quite accurate to say that girls who lived, or adolescents of a lower socioeconomic status faced greater sexual and gender-based violence during this period. So there are several reasons. One of them was because of general frustration period. So one of the girls said, on the father has been terminated from work and he comes to live with the family. So obviously somewhere they disagree with the mother. The second thing, which was also very interesting, is now because of the curfew hours, sometimes time went by without you noticing, and you're with this guy, and now he has a chance to do with you anything he likes because he knows you can't go anywhere. It's past curfew hours, you can't leave the house. So again, travel restrictions and the fact that we had curfew hours made it also contributed towards some of the sexual and gender-based violence cases that we noted. Finally, the last thing we looked at was the effect of COVID-19 and transactional relationships and transactional sex. And so what you find is that, so you may have girls, so typically young girls in Nairobi especially, but in most of the country, usually get into transactional relationships. And this is where in the relationships contain something, either money or a form of favor that might be financially quoted. and what's basically known as sponsorship. So during one of the surveys in 2019, we noted that about 86% of young women in Nairobi had received some form of resources from their most recent partner. Transactional sex, on the other hand, is different. It's whereby young people have sex for money, but with somebody or outside of their primary relationship. And what we found was that dependence on transactional relationships had actually increased during COVID-19. About half the women interviewed noted that they had increased dependency on such relationships. We also noted that a number of young women who previously were not engaged in sex trading, about 12% of adolescent and young girls reported that they actually had sex for money or for favor outside of their primary relationships. And about 37% of this began during COVID-19. So again, I think tying to the socioeconomic effects of COVID-19, we had increase in transactional relationships and increase in transactional sex. And of course, this is associated with violence risks of unintended pregnancy and so on. And so some of this, one of the effects of COVID-19 was actually to increase the transactional sexual activity taking place. So what's the way forward? What's the conclusion and what are the recommendations? So in summary, of course, COVID-19 was associated with disruptions in FP and menstrual hygiene products, which again created several SRH risks to young women. One of the things that ideally should be as a matter of urgency at this point is to increase access to the points of provision. So have pharmacies, over-the-counter services, providing FP services, access to menstrual health and so on. And then, of course, there should be a lot of quality counseling for adolescent girls and young people so that they can select their preferred methods, but at the same time so that they would understand the importance of seeking services in a timely manner. In terms of autonomy and privacy, this is something that's really hard to sort out because this is a very individual and dependent on the family scenario. But of course, especially bearing in mind the fact that girls were most affected, it would be important to come up with programs that target the youth with education and really critically engage them during this time when either they are not at school and when they might not be very comfortable at home because of the loss of privacy. In terms of gender-based violence, of course, we noted that there was an increase, especially for intimate partner violence. And what we should actually target is to encourage young people to report sexual and gender-based violence, and especially report intimate partner violence and enhance access to GBV services for young people. And for transactional sex, so while both of these are quite common for young people across the country, and of course, given the risks of transactional sexual activity, it would be very important for service providers to be prepared to address and respond to these relationships and to be able to provide the necessary services and counseling in a manner that's not condescending and that's very supportive to young people. So thank you very much. That's the end of my presentation. I hope I haven't taken so much time from the next presenter. But if there are any questions that you have, then we can put them at the end of the presentation. Once again, my gratitude to the entire research team, PMA, and that the First Time Young Mothers and UNFPA. Over to you, Professor Malu.
Thank you very much, Griffiths. This is excellent, very clearly presented, very sobering and pertinent issues, and we shall have questions on this, I'm sure. So thank you so much. Please remember to put your questions under Q&A. A few of you are doing that, but we're doing very well on time, so we'll have enough time for the questions. I'd like to move on to the next presenter, Dr. Diana Ondieki. Dr. Ondieki is going to give us a talk on social construct and around adolescent and youth health. Dr. Ondieki, I kindly take the floor.
So thank you very much. I'll request for my presentation to be put up. I believe Griffin will have to stop sharing.
Griffin, perhaps you could stop sharing so that Dr. Ondieki can share.
I've stopped sharing.
Thank you. Dr. Ondieki, your presentation is on.
So I'll be taking you through gender and sexual norms, social norms in adolescent sexual and reproductive health. Just an overview, adolescents make up 1/5 of the world's population. And according to the 2009 census, adolescents were 24%. But we saw from Bashir's presentation in 2019, they were actually 29%. So essentially, a bigger chunk of the population is comprised of adolescents. Early sexual initiation, which is considered sexual initiation by 16 years of age, the current global mean is at 15.4%. And there was this graph that was presented by Bashir that clearly showed at various ages the percentage of people who had had sex by that time. And the thing that I'd like to point out is that by 20 years of age, 71% of women and 76% of men have had sex. So essentially 3/4 of the population by the time they are 19, 20 years have already had sex, which is a considerable chunk of people. So it's important to note that our young people are having sex and that they're at risk of all that appertains to it: teenage pregnancies, school dropouts, mental health issues, unsafe abortions. And it's very important that we discuss this. So to be able to understand the gender and social norms that appertain to adolescence, it's important we understand what these terms stand for. So gender refers to the social construct, the roles, the behaviors, the activities that are attributed to men and women by society. And sex is the reproductive organs that a person carries. So this can be male or female reproductive anatomy, or for the intersex, it can be both. And for the intersex people, they tend to ascribe to whichever gender of choice. They might either choose to be men or choose to be women. When it comes to the social norms, these are expectations of a reference group, what people do and what other people think these people do. So our young people are driven by various sociocultural expectations about how to behave as men and how to behave as women. And this really informs their behavior. Girls are expected to do certain things, boys are not. And this creates a lot of gender imbalance, such that the expectations of the girl child are very enormous. And we've seen also parents, when they have a choice as to whether to educate the boy or the girl child, they will choose the boy child over the girl child, such that it is seen in most people you talk to, they value the boy child compared to the girl child. And we've seen women who will keep on having babies looking for that elusive boy. So these disparities manifest in a number of ways, and a lot of work has been done by the APHRC. One of the things we see is an equal power in relationships. There are sexual double standards. There is female genital cutting and also early marriages. Just to look at a few of them: an equal power in relationships. male dominance is promoted. And we've seen when people come seeking healthcare and you have to act and do something, they tend to say that you should wait for the male provider to come or the head of the household to come. And this tends to delay healthcare. Also, we've seen the issue of sponsors. The person who has the money has the power and drives sexual activity. And this has not only been seen with the girls, but also we are seeing boys taking up older women who are able to give them money in exchange for sexual favors. And this predisposes them to sexually transmitted infections, to intimate partner violence, and also to early parenthood. The issue of sexual double standards, we've seen essentially for boys, it's preferred for them to have multiple sexual partners, but for a girl, it's considered to be shameful. It's considered shameful, such that you're taken to be a prostitute. And the girls are expected to be responsible for their own sexuality and for their own safety. We saw this issue in the media the other day of a girl who met a boy on Facebook. They went out on a date, and because she refused this person's sexual favors, she was thrown off the 12th floor. And people were shaming her and saying that she was the one who was in the wrong, yet here she was a victim being taunted for refusing this person's favors. So it actually clearly brought out the issue of a person's own safety lying on the girl herself. Sexual prowess, men are driven to want to engage in sex in order to prove their masculinity and also to gain social recognition. And this has driven many of them into early sexual debut, into having multiple sexual partners. And this has led to a number of the conditions that we've talked about in adolescence. Early marriages, according to a UN report in 2016, they said that 39,000 child marriages are occurring every day. And in our own setup among the Maasai community, we've seen female genital cutting leading to early marriages. And as a result, girls experiencing complications of pregnancy and childbirth. And most of these girls are curtailed from attaining their highest potential because of these early marriages. Female and male circumcision. Those who are cut are considered to be mature and eligible to do adult things. It has led to early sexual debut and also to teenage pregnancies. I'm currently doing my PhD and I'm doing it in Nyamira County. And when I was speaking with one of the education quality assurance officers, he said, the whole structure was that once you got circumcised, you got married. But now they're circumcised when they're still in school. So you cannot stop school to go and get married, but now they feel like they have the permission to have sex because culturally they have been prepared, but they're still in school. So essentially, this was a person on the ground interacting with people on the ground saying that because of female genital cutting, people feel they're mature enough, they're adult enough to do adult things. Current society vis-a-vis the days of old are looking to issues of mentorship by elders, lack of role models, and societal pressures. So mentorship by elders nowadays is pretty non-existent. People are busy seeking out their livelihoods, they're hustlers. They don't have time to mentor young people, so essentially leaving them to their own devices. And as part of my PhD work, when I was speaking to a village elder, he said this was done by the grandmother and the aunts, but mostly the grandmother who are missing today. The grandmother would teach the girls, they would live together, and the grandmother would take care of them. So in cases where the girls engaged in sex, the grandmother would know, and this instilled discipline. So nowadays, this issue of mentorship is pretty hard to come by, unlike in the olden days where it was pretty automatic and there were structures in place to facilitate that. Rot in the society, we have a lack of role models. Parents are sometimes the perpetrators of wrong, and the children just follow in their footsteps. An example also was the women who participate in brewing Shanghai and brewing the local busa, and they drink their own brew and they are rowdy and pretty useless by the words of the person who was speaking. And their children just follow and do exactly the same thing. So this is a person who's engaging in a bad behavior, and the children are just following and doing the same thing that they're doing. The thing that came out strongly in my research was the issue of the post-election violence and poverty. This was reported also by Okwaru, whereby poverty is driving people to it's actually forcing their children, forcing parents to send their children out to have sex for money. And it has brought about a shift in social norms, whereby the people whom we expected to be the role models providing guidance are the same ones who are telling these young people, go out and get some food for us. One key informant said land is becoming limited in the county where I was doing it. Our main activity is agriculture. And as resources are becoming scarce, this brings about poverty at home, because they can no longer farm for economic activities. The farm is majorly subsistence. So they need to look for other alternatives of alternative ways of income. So as a result, there's pressure on the girl child, not only to meet their basic needs, but also to meet their desires to live like other people. And that is why sex is seen as a source of income. And then guidance and counseling teacher, and this was echoed by many guidance and counseling teachers in schools in Nyamira County, where I was doing my PhD. She said, sometimes they may come seeking leave from school in the name of seeking medication, but at the end of the day, you realize they're going to see their boyfriends. And the parents of the girl are aware, because they know they're going to be given something, and some girls would come with sugar or something, basic needs. So essentially people are just going out in order to get basic needs. One of the counties where I did the study was a settlement camp for people who had been affected by the post-election violence. And actually poverty was driving people in a very big way to go and seek, sending their girls out to go and have sex for income. Such that, and that was around 2007, 2008, and you can see in 2018, 2019, 2020, it's actually becoming an accepted thing for people to send out their people to go and seek out livelihoods. And we can only imagine with COVID and the pressures that we're getting, the higher cost of living that is happening around us, what is going to happen to our young people. So in conclusion, it's actually great that we are discussing this and challenging inequitable gender norms between the boys and girls. But then also we need to be aware that there is a shift in cultural values that is occurring, such that the context in which these behaviors are occurring are changing, and we need to also change with the times. Thank you very much. Over to you, Professor Omalo.
Thank you very much, Dr. Ndiki. Really very informative. We're going to our last speaker this afternoon, who is Ms. Patricia Acero. Patricia's talk is on the truth of the matter. She's going to give us lessons from Homa Bay County. I hope you're able to share your screen, Patricia, as we continue to put questions on the Q&A.
Thank you so much, Professor Omalo. I don't have a presentation.
Okay, that's fine. You may take the floor even without the presentation.
As has been shared, my name is Patricia Acero. I'm the current chairperson of the International Community of Women Living with HIV. I also coordinate activities at a small organization called DACASA. But the reason why I'm talking to you today is because of the work that we do with Kellen, who got some funding through DREAMS, and they do some activities in Kisumu and Homa Bay. I'm one of the facilitators working with the girls, the adolescent girls, in issues around sexual reproductive health, HIV, land and property rights. So as one of the facilitators, let me talk about last year. Last year in around November, after the lockdown had been lifted, we were able to meet close to 300 girls, 150 in Kisumu and 150 in Homa Bay. So after all the sessions, then we had issues talking about law and what girls can be able to do in case they are sexually violated, and also empowering girls with information on their sexual reproductive health. These are girls from 14 to 24 years. So during those sessions, when I picked exactly what was happening on the ground, and that is what I want to share. A lot have been said, but let me bring the girls' stories. One day when we had just finished a session about laws, and 14-year-old stood up and she spoke in Swahili. And she was asking one of the lawyers, if I was to knife somebody and kill them, would you lawyers protect me? Would you be able to stand in court and be my lawyers. And everybody was shocked because we didn't know where that was coming from. So at that particular time, the lawyer answered, but then we took her out later because we had what we call bonfire, where we had an evening session, which was informal. They could discuss anything. So we brought that back. And when we asked the girl, she told us that since she was 12 years, there's this man who comes from their village. And every time he comes back home, because he lives in Nairobi, her father asks her to go and to that man's house. That man is a bachelor. And she says the man is even older than her dad. Although he has a big house, but they are the only two of them in that house when that man comes back. So she's supposed to clean that house, cook for that person, and sleep in that house until that man goes away. And the girl told us that she's afraid that one of these fine days that man was going to molest her. So we asked what the mother was doing, and she said the day the mother opened her mouth, she was beaten thoroughly by the dad. So these are some of the things that parents are doing, exposing their children to be molested where they're living. The next one was from Bita. She shared with us that when her parents died, she was 17. When her parents died, they are living alone. She's living with her two siblings. But one night, an uncle knocked on the door and she opened, only to find the man half naked. So the man jumped on her, but the goodness is the house is a bit small, so the cooking place is not far. She grabbed one of the firewood and hit the man on the head and really struck him hard several times. So if this girl was not strong enough, she was going to be molested with an uncle, the real brother to the father, and that is an orphan. So when she brought this thing up with the grandmother and the other relatives, she was told to keep quiet, that uncle cannot do anything like that. So when we asked her, she said she was told, Tuolodonjeko, yani the snake has gone into a gourd. So that is a term that is being used so much to cover up all the incest and the defilement that is going on around areas of Homa Bay. So this is something that I think that as leaders, as people in this field, how do we pick that up? That orphans and vulnerable children are being molested and incest is going on, yet we have laws in place that can be able to tackle that. So as much as we are talking about policies or looking at the policies and having new ones, even the ones that we already have are not being used. We are not protecting the rights of girls. The other component was a group session that was held in Siaya. And this group session are girls who are HIV positive, but they're young. So people are talking about sex. And a 12-year-old was asking, she asked in Luo, what is sex? Because these other girls were saying sex, so she wondered what was sex? And then one of the girls explained in a simpler term that it's when a boy takes his penis and puts it in a girl's area, so saying in vernacular. And she was like, I don't like that game. I don't really like this game you're calling sex. Every time my grandmother leaves, my cousins jump on me and they want that game. She mentioned several names and said, so and so is so big. It really hurts me. But every time they're playing this game, I don't know what to do. So these are some of the things that are happening in the community. Those are the stories of the girls. So recently, a few weeks ago, from the stories that I picked from one of the girls who comes from a place called that is in Diwa. She told us that in their area, it's like almost any other girl is pregnant, is having a baby, is lactating, or is pregnant. And we asked why. And she said, because in that area, it is believed that girls have taken contraceptives and they cannot have children. And because of issues of poverty, the only thing that the way out is to get married. So if you can already be tagged that you cannot have a child, then the best thing to prove it is to get pregnant and have a child. And she said very young girls were pregnant. So when I shared this with the head of NAC, that is Dr. Masha, she said, Patricia, we need to go to this place and see with our own eyes. So we went to Ombokachien village. And what we saw, more than 60 girls, either pregnant or lactating. And they are from 14 years to 16. And most of them of that age are in primary school. And these are the stories they gave us. Some of them get pregnant just because they're looking for pads. they don't have pads, they don't want to go to school, and they have blood all over. So they are having a sexual relation with a boy just because of a pad. Others said they have no communication from their parents. Nobody tells them anything about what they need to do. Their parents are busy. They leave in the morning, come back in the evening, leave in the morning, come back in the evening. Others told us it's about poverty. They don't have the basic needs. If either you apply ng'ombe on your skin, and if you want maybe lotion, then your friend tells you you need to get yourself one of the boda boda guys so that they can buy you some lotion. And the worst part was when we got the community together, they told us that, especially the women, that the issue of incest is rampant. And when the women talk, they're beaten. And they're told this term of Tuolo Donjeko. The snake has entered the gourd. So how then do we as communities, as people doing these programs, think of programs that can protect the girls? How do we then have programs to prevent teenage pregnancies? Because working in the HIV field, I've seen the programs that are there for prevention of HIV. Because when girls are getting pregnant, I'm aware that the prevention component is not working for the adolescent girls. That component is not working completely. How do we intervene with the programs that can be able to save the girls from pregnancy, from HIV, from incest, from molestation? How do we work together to save the adolescent girl? Back to you, Professor.
Very, very much, Patricia. These are very, very sobering questions, very pertinent, and everybody's going to have, the panelists will also have a chance to comment on them. You've given examples, you've given the stories of the girls, you've touched on the rural area, and the other speakers had already highlighted that there's a disparity between rural and urban, and you have the examples you've given, I think, highlight that more than anything. So thank you so much. We shall, of course, be coming back to you. So colleagues, again, we've had all the speakers and we have the time now for discussion. The first thing I'm going to do is to go through the questions that were put on the Q&A. Some were very specific to different speakers, so I'll go through those. I'll take about 4 at a time, then we have responses. After that, we shall have everyone who wants to ask a question, you simply use the raise hand feature, you raise your hand and then I'll come to you. I'm hoping that at some point, Dr. Kunitha, we shall have a lawyer in this session. The questions that Patricia has asked demand that we have somebody who's well-versed in the law also speak to this session, because she's raised, in my view, very pertinent issues. So now the first questions as they came in, Ferdinand Kwaro, you were asked, you talked quite a lot comprehensively about the girls, but the question here is to make a comment on the boys, the teenage boys, what's happening with them. I think that is the question for Ferdinand. Dr. Bashir, you have many questions, and I'll pick a few. First is about, there is a condom dispensers everywhere, they're being used by males. The question is why don't we hear more talk about contraceptives for the teenage girl? That's the first question for Dr. Bashir. There's a question on sexual violence, and this is linked to the fact that you showed that it is highest in the younger girls. The question here is one that alludes to whether there is any bias in this reporting. I'll just quote, could it be that the older ages do not report much of the violence since they're adults? And they may be basically, could they be ashamed of reporting so that there's an over-reporting of the younger? I think that's a question on the data that we can hear from both Griffin, because you talked about that, and also Dr. Bashir. Again, to Dr. Bashir, why is government not in a position to trace adolescents that were affected by COVID-19 in terms of their rights. I think that's the way it's reading. There's also a question about maternal deaths. It seems that the girls and young women are disproportionately affected by maternal deaths. And this is a thought that from your data, I think they contributed about a quarter of the deaths, yet I think they don't contribute largely to the total deliveries. What could be the reasons? I think we can take that group first, that we can stop there and then have the responses to that before we go to the next set of questions. So this part of these questions are for Dr. Bashir, Ferdinand, and also Griffin. Please take the floor. We can start with Ferdinand.
Good afternoon, Prof. Omalo. Thanks a lot to the panel, to everybody, and to the questions that are directed to me. Thanks a lot. I'd attempted to discuss that briefly in the chat, but the brief answer I could get is, first of all, if you've seen the presentations by, I think it was mainly by Bashir and Griffin, is like, in my presentation, I was dealing mainly with the 15 to 19-year-olds, and generally looking at sexual debut, the issues that emerge for the boys at that particular time, not so many of them are sexually active, and not so many of them are open in accessing or trying to access sexual and reproductive health information and product. So naturally, based on the group I'm discussing, their issues are not that much as compared to the girls who have an earlier sexual debut, but also in view of the biology of the boy and the girl, most of the SRH issues will revolve around the girls. And the fact that at this level, most of them will be preyed on by the older girls. So even in the structure of our focus group discussions, we had more focus group discussions with girls than with boys. So that's mainly a bias, both for the methodology, but also for the nature of the needs and the biology of the group we are talking about. I'm sure, and as you've seen in the presentation by Griffiths, when you get higher, at a higher level, at a higher age, you have more and more of the boy issues emerging in the SRH arena. That's what I would say about that question for now. But we also, in our study, we are looking at also older men, and in the analysis of the older men, so issues of SRH by older men or older youth, 18 to 24, they become more prominent. Questions of drug abuse, question of use of FP methods like condoms, concern with STIs, but also concerns about those who may have impregnated their own colleagues. Like I said in my presentation, quite a number of same age pregnancies are occurring. So that's why there's less and less focus on the boys in my presentation. Over.
Thank you. And I've just got information that Dr. Bashir had to drop off, although he might still be able to respond to some questions. That means the other panelists have an opportunity to give their thoughts on these same questions that I've asked. So I hope you're listening. But let's start off with Dr. Manguro. You had one or two questions, and please comment on the other questions as well. Then we'll also have Dr. Kihara and Diana comment. Go ahead, Dr. Manguro.
Yeah, so thanks very much. I think the question that's of primary interest to me is the question on sexual and gender-based violence. And I think you asked, the question was that why do we have a majority of the people reporting being female? What's happening to the males? So that's interesting. A few years back, we looked at data from the Gender-Based Violence and Recovery Center at Coast General Hospital in Mombasa. And we looked at data over the last 10 years from 2007 to 2017. And it's interesting. So most of the people who actually report sexual violence, about 80% the survivors who were treated for GBV cases were girls between or who are less than 16 years old. And that's interesting. But the other interesting thing was that also for the boys who were treated for GBV cases, about 80% of them were less than 10 years old. So and this speaks of two things. One is that on average, majority of people who experience GBV are female. But among the boys who experience gender violence, they're usually much younger. So they might not fall within the age group, or they might not fall within the age that we're discussing. Most of them are usually less than 10 years old. And yes, most of them were basically sodomized by other men. So it could be two things, and I agree. It could be that the boys are being sexually violated, but they're not reporting. But it's also more likely that we are having much younger boys who are getting violated, and probably that's why they may not fall within the spectrum of what we're discussing today. I think what's important is both genders are getting violated, but there's a huge variation in the age groups of those ones, of the boys who are getting violated compared to the girls who are getting violated. I hope that answers the question.
Yes, thank you very much. There was also the angle of age, apart from just the boys. What about the older people? The older might be getting, there may be violence, but they're not reporting. There was also that angle. Do you want to comment on that?
Yes, it's true that we might be having older boys who are. I think it's true. It's true that we might be having older boys who are getting violated and not reporting. The main reason for that would be because of basically what the social norms. I think in one of the FGDs, one of the studies, I think one of the things is when a man went to report on sexual violence. I think you've even seen this on the news when a man recently went and said that he was being sexually violated, and the policemen at the station laughed at him and told him that, you know, you're being given, so you shouldn't be complaining. So it's very possible that the men who are being sexually violated, who are a bit older, are not reporting because of the existing social norms. Also because I think a second reason for this could be because of the design of the GBV centers. I think GBV centers, by and large, in our country are quite focused or designed to focus on the girls. And one of the things we need, and one of the take-home points here would be to have very, very integrated services so that the GBV centers are not standalone. The GBV centers should be very integrated to other health services, such that it's very easy for a man to walk in without feeling the fear or expectation of people knowing that he was going to report to be treated for GBV services. Because again, no one would know that they're going to get services for GBV because the services are very integrated to the other services. So yeah, I think in summary, while we might have a higher proportion of girls getting violated, there's also a high proportion of boys who are sexually violated who don't report because of either social norms or through the design of our health services or health systems that make it difficult for boys to report. Over to you.
Thank you very much. Thank you very much. I'd like Dr. Diana Ondieki to make a comment on these questions, followed by Dr. Kara.
Thank you very much, Professor Amalwa. I'll just use the illustration of Nyamira County, where I looked into some of these matters. For the boys, because I interviewed an equal number of boys and girls, over 200 boys, and their opinion was majority of their sexual partners were actually their age mates, people from neighboring schools. And this was both the same for day schools and for boarding schools. But then also I had an opportunity to have case narratives with two who actually openly said that they were sexually active with older women. And this was because they gave them a lot of money, they gave them whatever they needed. A person would have over like 10,000 a month or 2,000 per week. So essentially they were being given a lot of money. So for sure it's with their age mates, but then also there are those who go out with older women and they're actually open about it. And it was one of the sources of peer pressure. The need to conform and also to appear to have nice things. So it would make them to go out with these older women who would give them the money to be able to have that kind of lifestyle. On the issue of contraceptive prevalence, I did a study on the effect of religion on contraceptive use. And the contraceptive prevalence rate among 15 to 19-year-olds, according to the KNH 2014, is 30.2%. Against an overall contraceptive prevalence rate of about 53 to 57%. So I think 30% is pretty good for young people. And this did not matter whether they were married or not, above 18 or below 18. It was just about the same, ranging from 25% to 32%. But the overall contraceptive prevalence rate among young people was 30.2%, and this was modern contraceptives. So essentially, it shows these young girls are using they're using family planning. A very good chunk of them are using family planning. Over to you, Prof.
Thank you. Very helpful insight. Dr. Kihara, would you like to comment?
Yes, Prof. I think I'll change the tangent a little bit, and I want us to really focus why the girl. Why is it that the girl seems to be disproportionately more affected? Whether you're talking GBV, HIV vulnerability, we have the element of one, our biology. And put it very simply, the receptacle of the vagina is actually a hoarding station for semen. So unfortunately, if you are HIV positive, having sex with a young girl who even the system is still very immature, the probability she will end up with HIV is so much higher. But more importantly, Prof, is looking at poverty. And I want us to bring in an element of what we're now calling a multidimensional look at poverty. And what does it speak to? Health of the woman, health of your child. And for those who have children, I think you know, fending for basic needs, which marries very closely with living standards. Is she able to access water? Is she able to access an energy source to cook? Is she able to access sanitation? I think that has really come up so strongly. Is she even able to access a basic toilet? It may sound very, very way off, but in all honesty, you go to the IDP camps, you go into humanitarian areas, that is where the GBV happens. Basic needs. Then we have the element that speaks to education. Education in research has been shown. It's not just about the number of years of education, but it's what happens for you to even complete your education. What happens in terms of assimilation? And here we're beginning to talk more and more of teenage pregnancies, younger and younger girls getting pregnant. And we did mention the vulnerability associated with the brain development of that young girl, decision-making, risk-taking. If you were to actually look at the biology behind brain development, you actually realize in adolescence, when you start grooming elements that speak to relationships and sexual activity, vis-a-vis, you're not grooming elements that speak to intellect and having cognitive decision-making. This is why we begin to see differences. But I think, in all honesty, poverty is one area we must address. Education, if I drop out because my culture has taken me through FGM or FGC, where they then get early childhood marriages and therefore early sexual debut and early pregnancies. What can we do to change that norm? Because it is a practice that is well integrated in our cultural system. What can we do to change, to give alternatives? Vis-a-vis the neo-culture, I call it neo-culture, the girl who lives off a sponsor. How do we actually change that you can actually keep in school and eventually have the money to do everything that you would wish to do and not have to depend on a sponsor who eventually then gets you out of school, or you end up diseased and you end up out of school. So the same is happening for the young boy. And I think it was
Dr. Ondieki, who talked about even my other colleague, who talked about the border issue. Quick fixes. We as a nation, I think, need to really think, is border the ideal way to go? Or are we just giving marupurupus or quick money for just to subsistence? Does it give them really safety nets? Or are we still getting abject poverty from a very simple looking means of livelihood, vis-a-vis giving technical skills? You know, you can move from a formal system, either you get back reintegrated, or can you move then to an informal system where you actually have hands-on skill training? We're having issues with plumbers, we're having issues with welders. Those are practical skills that can actually give somebody a livelihood that is not only just subsistent, but will take care of this multidimensional poverty. Unfortunately, most girls, when they have to end up with sex, consented or unconsented, there comes out a progeny, which is another baby. So she ends up poverty. The product from her pregnancy is more predisposed to poverty. Again, look again at IDPs and the humanitarian crisis. COVID literally has brought on a humanitarian crisis, unemployment, job fallouts, kids who are just idle at home. I keep asking, where is healthy recreation in this country? Where is it? So that they have safe spaces, they can integrate counseling and guidance in those safe spaces, such that their minds are not a devil's workshop, because we all know idleness becomes the devil's workshop. So preoccupying them with things. As a young girl, you grow up knowing how to knit, you know how to cook, you know how to do those basic chores, but we've lost it. And then again, where is the parental responsibility? Where is their role? We're chasing our own tails, you know, and then saying, oops, at age 15, how come she got pregnant? Where are we? Dr. Ondieki alluded to the fireplace conversations with the elders. Where are the grandmothers and the grandfathers to guide the boy child, to guide the girl child? I think, Professor Wamalwa, in a nutshell, what I'm hearing is we need to go back to some of our own traditional, positive, constructive ways. And as for the harmful ways, we need to have a rethink on how we can change some of these value systems. But above all, can we readdress ourselves with poverty? Because it's not poverty of just the mind, it's poverty in basic needs. That is the problem.
Thank you. Thank you very much, Dr. Kihara, putting that context very clear. And all the speakers alluded to the challenges, poverty, basic needs, and thanks for putting it again in context. We have, I'm going through one more set of questions, and then we shall allow those who have raised their hands. And now the questions are as follows. The first one is, that the Ministry of Education has allowed pregnant and lactating adolescent girls to go back to school, but it has become an uphill task. Many do not want to go back to school. And the question is, how do we help these adolescents to go back to school so that we break that poverty cycle, the same one that Dr. Kihara is talking about? Because clearly, if they don't complete their education, it's a cycle. So that's the first question. How do we get them to go back to school? The ministry says they can go according to whoever's asking, and they must have some data. Hopefully they're not going as much as we would like. So that is the first question, and all the panelists will take a go at it. The second question, I'm going to really ask what Patricia asked, and her question was, it's a very broad question, but we can get one perspective from everybody. How do we intervene with programs to protect these girls? And I know Dr. Kihara has touched a little bit on it. There's also a question about the legal issues, saying that the legal adolescents or minor are not meant to access contraception without consent from the guardians. The question is, can they legally access family planning without parental consent? I guess you put an age on this. What will the law say on this? And there is a question specifically to Dr. Ondieki about the kind of contraceptions that was being used in what you described, meaning is it Depo-Provera or are there new methods? So I'll just go around again to hear answers on this, starting with the Ferdinand Kwaro, and then we'll go to Griffin. I'd like everybody to give their view briefly on these questions, and then we'll go to those who have raised their hands. I'm having all the panelists comment on the questions, and the first question is about how do you see us helping girls go back to school? The ones who have been pregnant, they've been allowed to go, but they're not going in the numbers that we would have expected. Any of the panelists? Go ahead.
I'm not so sure how to respond to that, apart from saying that this is an issue that I've been toying with around in my mind about, especially that concept of girls going back to school. There are a number of issues that we need to first try and understand. And as a researcher, I would want to call for more research on exactly what's the situation of girls reporting back to school. Because you're right, the ministry says go back to school, but it does not give any further directives or any further support of when do they go back to school, how do they go back to school, what is the environment within which they are living, both with the parents and also with the school environment. And it's something that has become very common, especially with COVID this time round and the increasing number of pregnant girls trying to go to school. You read about cases of girls giving birth in hospital, sitting exams in hospitals. And I often ask myself, well, even in mature girls in proper relationships, at work, when they need to give birth, they're given a time out to go and give birth and take care of the baby, maternity leave, etc. But we have a situation here where there's sort of a rush to want the girl to go back to school. I think there is need to assess the situation clearly about the needs of this girl who needs to go back to school. It's probably, to my mind, is that there is no proper setup that enables them to go back to school. There could be also an element of stigma that some of the girls, as soon as they become pregnant, the parents see that they've brought shame to the family. So there's also the fact that they may be pushed away from their homes by their parents. And so the only way out is for them to either get married or find a way out. The school environment is also sometimes not very conducive, but because from part of my background asking around within the education setup is that someone said to me, like in Western Kenya, the teachers are told to take the student to a different school because that school does not want to be associated with the pregnant girl trying to go back to school. So for me, is that there is need for a very conscious, very detailed or a very comprehensive look into both the educational, the physical, and the mental status of the girl that we're asking to go back to school, so that we can enable them or empower them, both not just them, it's them, the family, and the school environment, as well as the policy environment that ensures that they are comfortable enough to go back to school. And we need to ask ourselves essentially, both from the parent, are they like able, if they wanted to go to a different school? Because there are all questions of stigma, all questions of being laughed at by their colleagues that come into play. It's an area that is very gray, and they like It's a good approach that the Ministry of Health and also sometimes roping in Interior Ministry to ensure that the girls go back to school. In fact, the other day we had the Minister for, was it Interior, saying that all the girls who become pregnant must be looked for and they must be made to go back to school. Good policy, but the mechanics of its implementation is what we need to look at critically.
Thank you very much. Thank you so much. I'm starting to feel a bit of time pressure here. So I'll have, because I want to give the chances to those who've raised their hands for so long, and I promise that I'll do that. So we'll have the other panelists respond to the other question on the legal aspects of the younger girls and contraception. Any of them, Dr. Kihara, would you like to take that one? On the legal aspects, the young, do they need the permission, and so on. Please comment, Dr. Kihara.
Okay, I'll start from a very basic principle. She's already sexually active, and they're increasingly getting more and more sexually active the younger they are. We have the legal age as 18, and I remember there was even a debate as to whether we need to bring it down to 16, and it was categorically shut down. But when you read around, you actually find once a lady has actually become sexually active, they're considered as emancipated minors. And particularly if she's sexually active and has a child by that sexual activity. So, question of the guardian, it is now patient-centered focus. You have to actually get to deal with the individual grappling with whatever she has relating to her sexual debut or sexual encounters, be it the pregnancy, be it HIV, be it an STI, be it GBV, be it secondary to FGM and she's married off into polygamous marriage. So that's the long and short. I think we all need to go and look at the emancipated minor because it relates to sexuality in that age cohort.
Thank you very much, very clear. Dr. Diana, there was a specific question for you about use of contraception in the examples you gave. Was it DAPO or what kind of contraception was this?
Yeah.
So I had said the prevalence was 30.2%. And when you look at this distribution, majority, 47% of them were on DAPO, then 33% were on condoms, 13% on the implant, and only 6% on the pill. So majority of the young people preferred to be on the condom. On the issue of getting pregnant and being in school, what I saw in Nyamira County was schools would actually do a pregnancy test on all girls once they report to school. And once that was done and you were discovered to be pregnant, you were sent home to go and come back with your parents. And the purpose for doing that was to ensure that you had support and you were able to attend antenatal clinics. But most girls on that happening, they would actually drop off. As much as there's that choice to continue schooling while pregnant, they would drop off, give birth, and then go to a different school. So the option was to go to a different school just to avoid the stigma and to be able to carry on. Some parents, of course, were not supportive, and girls would be sent away to their grandparents and attend day schools in those places. And there was actually a lot of suffering as a result of getting pregnant. It wasn't really a good picture that I saw on the ground. Yeah, that's my contribution. And on the issue of parents can actually give consent for their sexually active girls to go on family planning. And so that's normally the dilemma. So luckily for parents who give consent for their girls to be put on family planning, that is clear. For those who've gotten pregnant and have delivered, they can be put on family planning because they're emancipated minors. So the challenge is this legal age, they're still under 18. So for the other group now, it provides a dilemma. But we know there are fellow providers who are offering family planning openly to anybody who wants it, so long as they're sexually active. Over to you, Prof.
Thank you very much. The questions seem to be...
Professor Amalwa, can I give a comment for just 30 seconds?
Go ahead.
I think on the question on what can we do with the programs, one of what I've noted would be very, very important would be to promote multi-sectoral collaboration, especially between the health ministries and the education ministries. I think for such a meeting as this, that's very important. It would be very interesting to see if there's anybody from the education ministry From my experience, and I remember, I think it was in Homa Bay County, we had a meeting to disseminate findings on a research on teenage pregnancies. And one of the things we noted was really the girls were having sex quite early. And it was important to bring an intervention either in schools or whatever kind of intervention that focuses these young people. And everybody in the health department really understood what that means, but we had a lot of resistance from the education department. So I think to address really sexual reproductive health issues in adolescents, it would be almost impossible to do anything without the support from the education department and without convincing them of the importance of such interventions.
Professor Wamalwa, I want to add on what my colleague has just mentioned. We were conducting a study in Kajiado County trying to understand why there was an upsurge of teenage pregnancy. And this was round about the same time the president actually mentioned that FGM ought to be abolished, and an interconsultative framework approach has actually been undertaken, where you have Ministry of Education, Ministry of Health, Ministry of Gender. And of course, we have to have finances. So we've even engaged the financial department because a budget must be allocated. And I think that's really the way we ought to go if we're going to address some of these issues that are coming up.
Thank you very much. That's very helpful. I'd like to have, we have 3 questions. People have raised their hands. And so if they could be allowed, they will ask their questions in this order. The first one will be Chirag Patel, followed by David Rotich, and finally Joseph Amianda. They'll ask their questions, and after that, again, we'll take responses from the panelists. So let those 3 have a chance to ask. Chirag Patel. So maybe I could just get confirmation that Chirag is able to hear and is able to unmute or has been unmuted.
Yeah, they have both been unmuted unless they're having their challenges on their side.
Thank you, Chirag. And Joseph Amianda, you may go ahead and ask your question. Right, so we seem not to be having them ask questions, although perhaps the questions have been addressed. I would assume that. Joseph Amianda and Chirag, you are able to ask questions. You've been given the go-ahead. So you can unmute yourselves and give the questions. Otherwise, we'll go back to the panel. We have a few minutes to start the closing remarks. And again, I'd like to go around to all the panelists. It's been really very exciting and very informative hearing the different facets of adolescent health, from programming to all the way to what the ministry is thinking, to the gender norms, and finally to stories from the girls. Patricia, do you have any comment at this point as we start closing? I know your question has partly been answered. The issues you raised, which are very pertinent, have partly been answered by Griffin.
Yes, I do.
Yeah, let's start with you. And this will be your closing remarks. Patricia, go ahead.
One, I would want to say that we need to think out of the box in terms of what we do, the adolescent girls, and issues about the teenage pregnancies. 2, there's a lot that can be done in terms of girls going back to school. Yeah. The little example I saw in Omboka Chian, There were some girls who were in school, who had gone back to school, who were lactating, but they were back in school. There were also those who were pregnant, but they were back in school. One is to have conducive environment within the schools. The other one that I saw was lacking is what kind of support can be given now to the grandmothers. Because they are young women, the grandmother, what type of support can be given to them so that they're able to take care of the kids as the girls go back to school. 3, age-appropriate sexuality education. If some of those girls had that kind of information, they would not have become pregnant. Those ones who had incest, the ones who were raped, they would have gone to the health facilities. So those are the specific areas that I would like to touch on. And in terms of issues of HIV prevention, I think we are lacking having targeted HIV prevention services for the adolescent girls and the young people. Back to you, Professor.
Thank you very much. And this issue of the issues you keep raising of incest and in the community, we actually haven't had a response, and perhaps in future talks in this symposium, that's an area that Dr. Kinude and team, it would really be good. I know the program is already made, but it seems to be a big problem that needs to be addressed with, especially I think a lawyer should give a talk in this symposium. Thank you, Patricia. Dr. Diana Ondieki, could you please give your closing remarks to this session?
Thank you very much, Prof. I'm very happy that we are having this symposium and we are discussing this critical group of people. Some of the things I feel we need to do is to, instead of coming up with our own suggestions, if it's possible to engage the stakeholders, the people on the ground, the young people, what they consider would help alleviate the matters that they are going through. So the fact of the matter is they're having sex, but now how do we address it moving forward? Because I remember Griffin or someone had said the issue of do you make them abstain or do you cause them to use family planning? The other thing we need to look into, incest was also very common in Nyamira County. Actually, it's either the parents or the brothers or the uncles that were actually having sex with these young people. So it's actually quite rampant, I can also say, in Nyamira County. And then the key driver, poverty. If there is a way we can improve the socioeconomic status of people on the ground, I believe this will help relieve that pressure that families are feeling and having to push their girls such that they don't really care about their values anymore. It's about survival. If this component could be improved, then it could actually help in alleviating the issues that we are seeing with our young people. Over to you, Prof.
Thank you so much for those comments. We'll go to Ferdinand, your closing remarks, please. Ferdinand, are you still with us? If not, I'd like to ask Griffith. I know you have given your closing on the programming, but you can also give overall closing remarks.
Thank you very much, Professor Wamalwa. On a more practical note, and given that we have quite a number of health workers in this forum who are listening, one of the things I've noted was that one of the barriers towards uptake of sexual reproductive health services for adolescents and young people are health worker attitudes. I think from one of our studies in Narok, there was a nurse who said she could not give adolescents family planning because she felt that when they use family planning, they're likely to become infertile in future. Of course, there are quite a number of myths and beliefs that exist out there. But for health workers, I think we need to take cognizance of the fact that sometimes we might have barriers towards adolescents taking up services, not necessarily family planning, but other services. And once we understand that we might also be the barriers, then we might either build capacity or change attitudes, but at least make it easier for adolescents and young people to take up SRH services. But other than that, thank you very much, Chair, and thank you very much for everyone in the audience. And I think this has been a fairly good discussion.
Thank you so much. And now, Dr. Kihara, you gave introductory comments, and I know you've put in quite a bit in between, but still I'd like some closing remarks from you.
Thank you, Professor Wamalwa. I'll throw some woodworks. Yes, we are now beginning to open the Pandora box of insurance for the youngsters, adolescents and youth. But my question is, what's the minimum SRH package that they can, one, get information, gain access, and obtain services without discrimination, patient-centered, rights-based? I'm emphasizing that. Number two is, none of us are looking at the perpetrators. So the boys and the men, when will you become responsible and accountable? Because I think that conversation should actually be put alive. Even by law, the legal address, even those of us who have done GBV and followed through with the legal system, it's very difficult to get perpetrators locked up. But how can we put stop gaps such that this does not continue? And lastly, data does not lie. I think all of us in this forum have realized there are gender disparities. Two, the girl is unequally more marginalized in the aftermath of whatever is happening in her sexual reproductive health and rights. But for both, we need to actually look at the evidence, have living policies, not policies that are on a shelf, living policies that can be implementable and carried through. This cannot happen without engaging the youngsters. That's the adolescent and the youth of this nation. Kenyans need to be awake to realize those are the people carrying the citizenry for tomorrow.
Thank you very much. And on that note, we know our time is up. It's exactly 4:30, and I'd like to thank everybody so much for attending this. There's another session at 5 for those who are able to make it. We've had a really exciting session. These are our children, our sisters, our nieces, our nephews, our parents. There's so many questions that have been raised. Some solutions have been proposed. And like one of the speakers said at the beginning, and like Marilyn said, how do we come in? What is our place? What is our attitude? So with those words, I'd like to then close this session. Thank you to all the panelists for a very, very good job. There were questions about accessing the material. I think KNH Research is going to make sure that you all get access to that, as well as the CPD points. Thank you.
Maybe, Wamalwa, I can mention about the material.
Okay, you can do that.
We must be able to gain consent from the presenters themselves, but they will then be put up on the repository, which will then be accessible to anyone who needs it. But consent must be given by my speakers before we do that.
Right.
Because some is research that's ongoing.
Okay, that's clear. Thank you very much. We adjourn this session.